years of age group. There are social factors such as prostitution, broken homes, sexual disharmony, poor socioeconomic status, and return traffic women, alcohol. And this is types of HIV epidemic. Generally, there are three types of HIV epidemic. That is low level of HIV epidemic, where the prevalence has not consistently exceeded 5% in any subdefined population, that is in a high-risk group. High-risk group, it may be people who inject drug, sex worker, it may be male, it may be female, friends of or clients of sex worker, labor migrants. So these are the high-risk group. Concentrated HIV epidemic. So prevalence of HIV is not prevalence of HIV is over 25%, 25%, at least in one subdefined population or high-risk group. So prevalence of HIV is more than 5% is one high-risk population or subgroup, but less than 1% in pregnant women in urban areas. So that is the concentrated HIV epidemic. Nepal is facing concentrated HIV epidemic, where the population prevalence is more than 5%. So male sex worker population is more than 5%, but less than 1% in pregnant women in urban areas. And another is generalized HIV epidemic. HIV prevalence is consistently over 1% in pregnant women. So that is a generalized HIV epidemic. It is more than 1% in pregnant women. So you can see in this picture, male sex worker prevalence is 6%. So these are the high risk group I have already discussed. And mode of transmission mainly unprotected sex. So that is the heterosexual. If you talk about the case of HIV and AIDS, so more cases are from heterosexual contact. So unprotected sex is the main route of transmission. It may be anal, vaginal, oral, and the size of the risk is affected by numerous factors such as presence of STD. If there is syncope or peace, then the chance of transmission is greater by 8 to 10 times. Similarly, sex and age of the uninfected partner. Sex, if it is female, there is high risk because semen concentration high. Semen contain high concentration of the virus. Similarly, female has larger space to exposure. Similarly, age, adolescent age, and postmenopausal woman, their cervix is thought to be less efficient barrier for HIV. Type of sexual act. So obviously, anal is a riskier than other because there is high chance of abrasion of the tissue, broken of the tissue of the receptive partner. The stage of illness, obviously, it may be first stage, initial stage, where the viral load is high, and later stage or advanced stage of the AIDS. So that is the stage of illness. And virulence of the HIV strain, that is type 1, is the more virulent than type 2, and it is most common. Similarly, sharing of contaminated injection equipment, tattooing, skin processing tools, and surgical. So that is the second mode of transmission. Third, through infected blood and blood product. 4, so it may be transmitted during pregnancy, during labor and delivery, through breastfeeding. So through breastfeeding, almost chance is 13%. And from pregnancy to breastfeeding, total chance is 30 to 45%. So this is overall with breastfeeding to 18 to 24 months, 30 to 45%. During breastfeeding, 5 to 20%, but we can say 13%. During breastfeeding, chance is 13%. Okay, we discussed earlier. And prevalence of HIV, according to annual report 2017, it was 0.15. So this is the prevalence of HIV and AIDS, 0.15. Male 0.12, female 0.18. So this is the prevalence. We have to know the prevalence of HIV and AIDS. So prevalence is 0.15. So this is the current prevalence. So this is the clinical manifestation. Initial infection with the virus and development of antibodies. Then asymptomatic carrier state, AIDS-related complex, and AIDS. So we discussed in last class. Okay, next is WHO clinical staging. So till now we discussed previous class. So from today, or it is around 8:18. So we'll cover the remaining part. So this is the first slide of the second day. WHO clinical staging. Clinical stage first, there are 4 stages. So in first stage, that is asymptomatic because there is window period. Window period contains around 2 to 12 weeks. 2 to 12 weeks. So window period, we cannot detect the virus in the blood, or we cannot identify the antibody in the blood. So this is the asymptomatic stage as well as window period. So in stage 1, there is asymptomatic stage including window period. So during window period, we cannot find out the antibodies formation or HIV virus. Next is persistent generalized lymphadenopathy. So persistent generalized lymphadenopathy, that is the enlargement of lymph node larger than 1 centimeter in diameter in 2 or more sites other than groin at least 3 months. So that is the persistent generalized lymphadenopathy. So there is an enlargement of lymph node. So that is the clinical stage first. Then clinical stage second, unexplained moderate weight loss, but less than 10%, not more than 10%. In stage 3, weight loss more than 10%, but in stage 2, weight loss less than 10% of body weight. Then recurrent reproductive tract infection, RTI, respiratory tract infection. In respiratory tract infection, it may be sinusitis, tonsillitis, pharyngitis, and otitis media. So these respiratory tract infection may be recurrent. Once it present, then subset after some time, again it may reappear. So recurrent respiratory tract infection. Then herpes zoster, angular cheilitis. So cheilitis, that is the inflammation of the lips. It may be recurrent cheilitis, recurrent oral ulceration, papular pleuritic eruption, pleuritic dermatitis. Similarly, in clinical stage 3rd, moderate weight loss but less than 10%. In stage 2, that is less than 10%, but in case of stage 3, weight loss more than 10%. And chronic diarrhea longer than 1 month, and fever more than 37.5 degrees centigrade. It may be intermittent, it may be constant, but more than 1 month. So these are the major criteria for HIV/AIDS surveillance. We will discuss in next slide. So weight loss more than 10%, diarrhea or chronic diarrhea more than 1 month, and fever more than 1 month. Then persistent oral candidiasis. Then oral hairy leukoplakia, there is firmly white patches which is stick in the mucous membrane of the mouth, is shown in picture. That is the oral hairy leukoplakia. So it is firmly white patches which is stick in the mucous membrane of oral cavity, and pulmonary tuberculosis may be present. Then severe bacterial infections such as pneumonia, emphysema, bone or joint infection, meningitis, or bacteremia. So that is the severe bacterial infection. Then acute necrotizing ulcerative stomatitis. Stomatitis is the inflammation of mucous lining of the mouth. Gingivitis or periodontitis. And there is also associated with unexplained anemia or severe anemia, less than 8 gram per deciliter, neutropenia less than 500, then chronic thrombocytopenia, that is less than 50,000. So it is also associated with anemia, neutropenia, and the thrombocytopenia. Neutropenia less than 500, 5,000, then thrombocytopenia less than 50,000. Okay, stage 4, there is HIV wasting syndrome. That's why HIV/AIDS is also known as SLIM disease. Because in the late stage of AIDS or advanced stage of AIDS, there is wasting. HIV, that is called HIV wasting syndrome. That patient becomes lean and thin because of there is weight loss more than 10%, diarrhea, which is also associated with weight loss and fever, especially weight loss and diarrhea. Then pneumocytic pneumonia, recurrent severe bacterial pneumonia, chronic herpes simplex infection, oropharyngeal candidiasis. In stage 4, there is extrapulmonary tuberculosis. In stage 3, there is pulmonary tuberculosis, but stage 4, it may be extrapulmonary tuberculosis. So HIV/AIDS is also associated with tuberculosis in stage 3, pulmonary tuberculosis; in stage 4, extrapulmonary tuberculosis. Kaposi sarcoma is also present. So it is a tumor featuring reddish brown or purplish plaque on mucous membrane and skin. So that is the Kaposi sarcoma. Cytomegalovirus infection, CNS toxoplasmosis, and HIV encephalopathy. So there is CNS affected. That's why there may be hemiplegia, stroke, then altered sensorium. This clinical feature may be present. So this is the diagnosis of AIDS. This is the WHO case definition for AIDS surveillance. So mainly it is given for AIDS surveillance. So it is divided into major criteria and the minor criteria. In major criteria, that is weight loss more than 10% body weight, chronic diarrhea more than 1 month, and prolonged fever more than 1 month. That fever may be continuous, intermittent. So that is the three major criteria, that is weight loss, chronic diarrhea, and the prolonged fever. Similarly, minor criteria, persistent cough more than 1 month. But if the patient is suffering from the tuberculosis or other respiratory tract infection, that persistent cough may not include it for minor criteria. If the person is suffering from especially tuberculosis, so persistent cough may not consider in minor criteria, but other or accept that persistent cough more than 1 month is a minor criteria. Then recurrent oral pharyngeal candidiasis. So this is a fungal infection of pharynx. Persistent generalized lymphadenopathy, again. Recurrent herpes zoster. So diagnosis is made on the basis of presence of at least two major and one minor sign. So it is especially designed for AIDS surveillance. If there is two major and one minor, then so that is the case of AIDS. But there is other condition. If there presence of either generalized Kaposi sarcoma or cryptococcal meningitis. Kaposi sarcoma, that is tumor featuring reddish brown or purplish plaques on the mucous membrane and the skin, either Kaposi sarcoma or cryptococcal meningitis. So it is a fungal infection in meningitis. So clinical feature presents with fever, neck rigidity, vomiting, attack. If such symptoms present, either Kaposi sarcoma or cryptococcal meningitis is sufficient for diagnosis of AIDS for the surveillance purpose. Either Kaposi sarcoma or cryptococcal meningitis. So this is the AIDS surveillance. So this is the WHO case definition for AIDS surveillance: two major, one minor, or Kaposi sarcoma or cryptococcal meningitis. Okay, diagnosis. So that is RDT test, rapid diagnostic test, which detect the antibodies, whether antibodies present in the blood or not. It doesn't detect the virus oneself, it detects the antibodies. So that is serological test, RDT test. So that is ELISA test, another one RDT, other is ELISA, enzyme-linked immunosorbent assay. So it is the sensitivity test. So if ELISA is positive, another test is preferred, that is Western blot test. So this is the confirmatory test. This is confirmatory test, and its specificity is more than 99.99%. So if it is suggested positive from ELISA, Western blot test is done, then it avoid the false positive result. If it is recommended from the ELISA, it was positive from ELISA, and further refer in Western blot test, then in Western blot test, it avoid the false positive result. So this is confirmatory test. And there is other base or criteria, that is HIV viral load test. And other important test is Cd4 counts. So Cd4 counts, so this is the level of Cd4 count. Generally, normal level of Cd4 count is 500 to 1500 or 1450, around 500 to 1500 cubic millimeter per cubic millimeter. That is not significant in immunosuppression if it is more than 500 cubic millimeter per cubic millimeter. And if Cd4 count is 350 to 499 per cubic millimeter, then there is mild immunosuppression. If it is 200 to 349, that is advanced immunosuppression. If it is less than 200, there is severe immunosuppression. In this case, or Cd4 is less than 200, then there may be lots of OIs. Opportunistic infection may be present with CD4 less than 200. So this is the level of CD4. And then next is CD4 lymphocyte percentage. So normal percentage is around 25 to 65. But if it is less than 14%, then that is again associated with opportunistic infection. That is the very low. If it is less than 14%, generally 25 to 65, that is the normal. But if it is less than 14%, so that is the at risk, or it is associated with opportunistic infection, that is advanced stage. Okay. Next is HIV testing and counseling. Previously, it was known as BCT, voluntary counsel and testing, VCT, but now it is known as STC, HIV testing and counseling, test and counsel. So this is a process by which an individual undergoes the counseling, because counseling is important. After counseling, that person takes decision whether that person go through the test or not. So choice is in the individual side. After counseling, that person has to decide, yes, I go through STC or not, I'm ready to test or not. So this is the voluntary choice. Previously it was known as BCT, voluntary. So this is the right of the patient or the person, individual. So enabling him or her tested to make an informed choice about being tested for HIV. So it is about counseling and testing. By providing all information regarding HIV/AIDS, then he will take decision, I am ready or not. So that is the STC. So these are the principle of counseling. So it is time management also, trust and confidentiality, the counseling part as well as the disclosure of result. This should be strictly confidential. It shouldn't be disclosed. Acceptance and unconditional support throughout the journey. If the person is HIV positive, then support throughout the journey or throughout the life. Because once infected throughout the life. Better. Non-condemning attitude. So non-condemning attitude, we cannot say you did this, you made mistake, you made wrong. We cannot say. So that is the non-condemning attitude. Consistency and accuracy. Then accessibility for tests, accessibility for further counseling, accessibility for if the person is positive, then later heart, that is highly active antiretroviral therapy may be there. So that is accessibility. Informed consent, we have to inform or we have to give all the material, health education, counsel, we have to inform or convey the message, and that individual take the decision. And it is also associated with socio-cultural consideration. So counseling, it may be pre-test counseling, it may be post-test counseling. There are different counseling, there are different types of counseling, but mainly pre-test counseling and post-test counseling. Pre-test counseling, so before test, counseling provided regarding transmission, how the disease is transmitted, what are the risk factors, how it is transmitted, what are the mode of transmission, and what are the risk factors, and how it can be prevented. And the report will be confidential, whether positive or negative. That report or that final result will be highly confidential. So that is the pre-test counseling. Post-test counseling, that is the clarify the test result, release the result, whether that is positive or negative. And according to report, either negative, the counseling may be different. If it is positive, counseling may be different. Style may be different. Content may be different. And promotion of the safe behavior in both cases. Next is targeted intervention. So these are the vulnerable group. IDUs, intravenous drug user. Now it is also known as PWID, people who inject drug. PWID, people who inject drug. Previously it was known as IDU, intravenous drug user. Now it is known as PWID, people who inject drug. So what are the interventions for that group? Advice and counseling on health. So how the disease transmit. Because generally they use single needle and syringe for many partner, many friends. If there are 10 friends, they use single syringe and needle. So we can conduct one program, that is needle and syringe sharing program. So we can provide new syringe, needle syringe, and they have to show their used needle syringe. So needle syringe program can be conducted. So we can provide the new needle and syringe. And drug substitution. So drug substitution, mean if they are drug user, so we advise them quitting the drug. If it is not possible, then convert into ID to oral. If they're using intravenous, then we can transfer them or convert them into oral. If they are taking injecting form, then we can suggest them for oral drug. But ultimately, we have to request, we have to advise, we have to counsel for quitting the drug. Harm reduction and rehabilitation and referral to other treatment services for IDUs. And men sex with men awareness. So how danger it will be if there is anal intercourse. And behavior change communication activities, correct and consistent use of condom. So condom use is also important in MSM. There is only one method from prevention or stoppage of the disease, especially prevention from the disease, is the condom. It may be male condom, it may be female condom. There is only one method from prevention of this SIVs, especially hepatitis B also. So that is a safe sex by using condom. Then female sex worker and the client of female sex worker, there is promotion or provision of male and female condom, awareness, income generating activities such as saving and STI management. If there is STI, especially there is injury, it may be syncoid, it may be herpes, so chance of transmission is 8 to 10 times. Then migrants awareness, that is migrant, that is we can say labor migrant. So they used to work in one place for a while, then after finishing work they move to other parts, so that is called labor migrant. So they are also at risk. So awareness, how it can be transmitted and how it can be prevented. Then proper settlement and mobile STC, HIV testing and counseling. So they are the targeted intervention. Okay, prophylaxis and treatment. Prophylaxis and treatment. So it may be post-exposure prophylaxis, PMTCT, prevention from mother to child transmission, and antiretroviral therapy, that is HAART, HAART, highly active antiretroviral therapy. So first, post-exposure prophylaxis. So it is divided into low risk and high risk. In this condition, so that is the low risk, blood on mucous membrane. Only blood on, there is no cut, but blood on mucous membrane. A splash of blood onto abraded skin, needle, superficial injury, not deep, but superficial injury. So these are the low risk. And the high risk, exposure to body fluid, semen and vaginal secretion contaminated with blood. It may be fluid, semen and vaginal secretion contaminated with blood. So that is the high risk. Exposure to needle that had been placed into vein or artery. So directly punctured or placed in vein and artery. If it is superficial, that is low risk, but if it is directly placed into vein and artery, so that is the high risk. Deep injury, needle stick injury, so that is the high risk. Okay, for post-exposure prophylaxis, it is recommended, if it is possible, then preferably or highly recommended within an hour. Within an hour, that is the best. If it is not possible, within a 4 hour. But if it is also not possible, then within 24 hours. So generally, preferable within an hour. If it is not possible, within 4 hours. Also, that is not possible within 4 hours, at least for within 24 hours. But again, it is not possible in 24 hours. Then at least, that is the maximum period, at least within 72 hours. At least 3 days. So that is the maximum period, preferably within an hour, 4 hours, 24 hours. If it is not possible, at least 72 hours. After 72 hours, that doesn't work generally. So post-exposure prophylaxis is mainly recommended for first day within 24 days, but not more than 72 hours. And post-exposure prophylaxis, PEP given for 28 days. And the follow-up HIV testing is recommended at 6 weeks, 3 months, and 6 months. So for 28 days, it is given. And this is the WHO key recommendation for adult. That is the tenofovir combined with lamivudine or emtricitabine for adults. Previously, zidovudine and lamivudine evidence was there, but previous regimen was changed to tenofovir combined with either lamivudine or emtricitabine (FTC) is given, and for children, zidovudine and lamivudine is given for less than 10 years. Okay, it starts with pregnancy because PMTCT is done. If it is possible, then at first visit during ANC, antenatal checkup. So first ANC is done in at 4 months. So at least 4 minimum ANC visit is required. That is at 4 months, 6 months, 8 months, and 9 months. So 4, 6, 8, 9. So first visit is done at 4 months. So mainly this test, HIV test, that is a RTT test, is done at 4 months. If it is not possible, it can be done during labor or before delivery. If it is not possible, then during delivery or after delivery can be given. So generally, it is identified during pregnancy. So at 4 months. So if it is positive, then start in the pregnancy, continue throughout the pregnancy, labor, delivery, and postpartum, and for throughout the life. Because if it is once infected for throughout the life. So this is the recommendation, that is the zidovudine 300 mg twice a day plus lamivudine 150 mg twice a day, nevirapine 200 mg once a day for 14 days. If there is no reaction, then continue zidovudine and lamivudine and increase the nevirapine dose. Previously 200 mg once a day, but if there is no reaction, then 200 mg twice a day for 14 days. Or there is another regimen, zidovudine, lamivudine, and efavirenz 600 mg once daily. So this is for mother. And for neonate, that is nevirapine only, once daily for 6 weeks. So dose of nevirapine is 10 mg if the birth is less than 2.5 kg. If the low birth weight, 10 mg. If the normal body weight, that is a 15 mg. For normal body weight, 15 mg. If LBW low birth weight, 10 mg of nevirapine. So other drug is not given for neonate. Okay, principle of ART. So that is the therapy, highly active antiretroviral therapy. So that principle is reduction of HIV-related morbidity and mortality. So prevention from the morbidity. So control of opportunistic infection. But there is no aim or principle of ART is cure the disease, because there is no cure of the disease, but halt the progress of the disease, interrupt the progress of the disease. So reduction of HIV-related morbidity and mortality, reduce the mortality and prevent from the opportunistic infection. Improvement in life quality of improvement in the quality of life and prolong life of infected person by suppressing HIV replication, not by the destroying the virus. So there is no principle of the destroying the virus, but halt or suppressing the virus replication. So thereafter improvement of the quality of life and prolong the life. So this is the principle of ART, or we can say HART, HART, HART. Control of AIDS. There are 4 basic approaches. That is prevention, antiretroviral treatment, specific prophylaxis, and primary healthcare. In primary healthcare, there is accessibility of basic health services. Basic health services which is available from health post, PSC, and hospital as well. So provide basic health services. So that is the primary healthcare. Prevention, education portion is very important. So education is the vaccine. Education is the vaccine for the disease, so which prevent from the transmission. And prevention of the blood-borne HIV transmission, that is also comes under education also. But there is separate point, prevention of blood-borne HIV transmission. And antiretroviral, that is WHO recommended ARV treatment schedule and ART recommendation for the infant and children. And there is specific prophylaxis also. So prevention, so it is related to education or or rising awareness. In rising awareness, to be faithful to the partner, have monogamous relationship, not polygamous relationship. Monogamous relationship is the best way. Only one girl and boy, or husband and wife. So sexual contact only within couple, not extramarital affair or not polygamous relationship. So have faithful partner. If it is outside the partner, use condom. Correct and consistent use of condom and promotion of the safe behavior as a whole. Avoid use of shear razor and toothbrush because that is also possible source or possible source of transmission or tools of transmission. So people who inject drug should be informed not to share the needle and syringe. We covered earlier also. Distribution of IC materials related to HIV awareness. Distribution of IC, it may be a pamphlet, it may be poster, or we can use different media for advertisement, radio, television. There are different types of media, audiovisual, audio method, visual method, audiovisual. So TV and radio is the best for advertisement or making program and start or convey from the radio and television. So from broadcasting, especially for broadcast from the radio and television. So it may be advertisement, it may be a special program can be built up and broadcast from the radio and television. Provision of blood safety, so prevention of the bloodborne HIV transmission. People in the high risk group should be urged to refrain from the donation of the blood, body organ, sperm, or other tissue. All blood should be screened before transfusion. So there is provision also. There is strictly the blood, all the blood should screened before the transfusion. Strict sterilizing techniques should be applied in hospital and clinic, especially for surgical instrument equipment. It is strictly sterilized, and for injection there is auto-disable injection, only one use, single use, auto-disable. So it is also known as auto-lock. Auto-lock needle and syringe is provided. So generally auto-disable AD syringe is used. Avoid injection unless they are absolutely necessary. And for correct and consistent use of condom, generally there are 6 C's related to condom. That is the compliance. Compliance means use always or frequent. Contact treatment. Contact treatment, that is if once one individual is infected with HIV or STD or STI, then inquire about the partner of that infected person. So inquire about the partner, then treat other partner. That is the contact treatment. Condom promotion, counseling, especially for correct and consistent use of condom. Continued support, collection of essential data. So this is related to condom, 6 C's. And this is the specific prophylaxis. In specific prophylaxis, that is the primary prophylaxis against pneumocystic kidney pneumonia, should be offered to the patient with low Cd4 count, especially less than 200, or generally heart issues whose Cd4 count is less than 350. The regimen available are cotrimoxazole, that is the trimethoprim and the sulfamethoxazole. So this is the cotrimoxazole prophylaxis therapy. Then prophylaxis against Mycobacterium tuberculosis, that is 300 mg isoniazid daily for 9 months to 1 year. It should be given to all HIV infected patients with PPD reaction. Is more than 5 mm in duration. If there is PPD reaction, then isoniazid can be provided, 300 mg isoniazid for 9 months to 1 year for prophylaxis against Mycobacterium tuberculosis. Then if there is Kaposi Sarcoma, which can be treated by interferon, chemotherapy, or radiation. If there is Kaposi Sarcoma or for Kaposi Sarcoma. Cytomegalovirus retinitis can be controlled by glycine. So cytomegalovirus retinitis, the inflammation of retina, which can lead to blindness, it can be controlled by ganciclovir. And the cryptococcal meningitis, which present with fever, vomiting, headache, rigidity, so it can be presented or controlled by fluconazole. Similarly, esophageal candidiasis, or recurrent vaginal candidiasis can be treated by fluconazole or ketoconazole. So again, it is the fungal infection, so it can be treated by fluconazole or ketoconazole. And herpes simplex infection and the herpes zoster can be treated with acyclovir or foscarnet. So generally, acyclovir can be given for herpes simplex and herpes zoster. So this is the specific prophylaxis. Okay, thank you. We have finished HIV and AIDS. Okay, next time I'll do other disease. Okay, that's all for today. Thank you.
Thank you, sir.
Thank you, sir.